So ladies and gentlemen, today I have an expert. If you are someone who has been asking about genetics in cancer, then this is your episode. And today I'm with who?
Okay, thank you very much. My name is Syokau Ilovi. I'm a physician and geneticist based in Nairobi, Kenya. My area of expertise is dealing with patients and family with genetic disorders. Yes, so when we're talking about cancer, we are talking about cancers that seem to run in families.
Okay.
So then we're able to provide answers to what can be going on.
What does genetics involve? Yes.
So genetics is the specialty that deals with genetic disorder. What that means, there's a reason you look like you and I look like me, right? We got a blueprint from our mom, our dad, and sometimes we get our own version that we didn't inherit. A code, kama tu computer code that gives your cells and your body instructions. You will be this tall, you will be this color, right? You will have, your heart might have certain diseases like or red blood cells, so it can give instructions for normal things. Unfortunately, with anything that is being produced, kunaweza kuwa na shida, mali formula inaharibika, so then that's where genetic disorder comes on. So kazi yetu sasa is to try and figure out what genetic disorder somebody has. There are some treatments, although treatments inakuwa expensive, but then ukianza now when you're dealing with families, watu wanataka kujua, okay, so something is happening in our family. Tukiangalia what we have in our family, the cancer is there in almost every family. Lakini there are some families we can all agree, hata ukienda kwa community you can see hapa it's more than usual. So we begin to provide answers because people come to me even if they are not affected by cancer, wanauliza there's something that runs in my family. Do I have it? And very quickly followed, what is the risk to my children? Hata wale wamezaliwa, hata wale wanafikiria uko mbele, wanataka kujua, okay, so then if I have it, what is the likelihood that watapata? So it's just giving people answers to already what they can see and now begin to now form a plan of management.
And someone might be asking, this genetic testing, ni damu inatolewa ama it is a sample, a biopsy inatolewa? How is it done?
Inalingana because tumesema hizi heritable nini ziko kwa in all cells, right? So sometimes inaweza tolewa kwa damu, sometimes hata ile biopsy mtu alifanywa ya breast cancer inaweza tupaanza kupatia hiyo majibu, hata saliva, hata a buccal swab, kutoa sample kwa the inside of the cheek. So all those are viable testing. It depends na ile lab. Some labs wako na protocol ya hii sample, right? But kwa ufupi any cell can work. Hata ile cell haina cancer. Tuseme saa zingine watu wanakuja nasema my mom we suspected lakini hayuko sasa, alituacha. Lakini kabla aende alikuwa na breast cancer, lakini kabla aende hata ile ilifanya atuache alikuwa na fibroids na labda akableed, lakini hiyo sample ya uterus iko kwa lab sama. Kumbuka hiyo uterus haina cancer, lakini because you are looking at all cells inaweza anza kupatia majibu ya hii familia. So it's about any cell. Blood is a very nice sample kutupatia genetic test results.
So it doesn't need a procedure, a big procedure. Even a blood sample is enough to. Okay. And then someone might be asking, common mwananchi, umesema affordability ya this genetic testing is a bit expensive. How expensive is it?
I want to answer that question na kuuliza swali ingine. Unajua, tumesema there are very many competing interests kwa mifuko ya Wakenya,
yes,
si ndio?
Yes.
So saa zingine it's expensive, we will not lie, si ndio? Lakini uzuri ni as technology becomes ni kama simu. Wakati simu ilikuwa
kidogo chache,
lakini sasa bei so they'll get cheaper. Lakini saa zingine huyo mtu sasa anahitaji hiyo genetic test, hawezi ngoja 2-3 years nini because mwili wake bado unaendelea kuwa na shida. So it's just trying to look at the benefits because at the end of the day the money must come from from somewhere. It's expensive, but the benefits hata si ya mtu mmoja inaanza kupatia, because mtu anaweza sema amekuwa hata even just peace of mind, right? They are 55 from when they were children, they could see there was something wrong in their family. Hiyo kitu imekuwa ikimfuata. Akifika 55 afanye hiyo test apate aliyepuka. Tutasema hiyo pesa imeharibika, imekunywa maji, because imempatia peace of mind. Anaona sasa hawa watoto wangu hiyo njia hawatapitia. So even peace of mind, hata even if it's they are found, now they know they can begin to take steps. So it's an individual choice, and even most cases responsibility kuona kama hii ni njia.
And thank you for that. I had a patient and aliniuliza hiyo swali, ikabidi nimemwambia, you know, sometimes weigh the advantages and the disadvantages, you'll find that you'll spend more if there is cancer than if you had done screening. And some might be even paying even close to $1 million per year. Now your genetic testing, I think it's less than that $1 million. Na itaokoa pia the life. So it's something that we will try to balance. But then now to the common mwananchi, is it possible that insurances, not specifically SHA, to cover the costs, ama is it private insurance, are there ways that inaweza kuwa incorporated in those insurances?
That's a very good question, and that's a discussion that has been ongoing with a lot of support. But ultimately, right, things, insurance, whether it's SHA, whether it's what, are driven by policy, are driven by demands. When there's an increased voice, then people find it easier to cover. I want to take you back to HIV. When I was a medical student, HIV was not covered. But now you find HIV is not stigmatized, because first there is a need, there's an agenda that is driven that how come you're covering kidney, dialysis, whereas these are also still human beings, right? So it's, and even from an insurance perspective, you have to create a need for them to see, okay, there's a critical mass, this is something we can begin to engage. And I believe those conversations are ongoing, right from the national insurance to even private players.
And now, dealing now specifically, because our episode will be dealing on breast cancer and genetics involved in breast cancer. Does genetics play a role in breast cancer, and how big of a role does it play?
So that's a very good question. The short answer is absolutely. But then now, that is the simple answer. But it's not, you know, by the time somebody is getting, either man, woman is getting breast cancer, there are a lot of factors that have happened. They might get breast cancer at 50 years, but your journey has taken decades, right? It can have started before birth if they had a genetic predisposition to developing cancer. It also comes into play environmental, if that somebody smokes, the kind of lifestyle we are living, and that's what is driving hii cancer imeongezeka, because we can all attest we are in 2026. The amount of cancer that is in the community now is not the same that was there 40 years ago. And that doesn't point to genetics, that points to environmental, because genetics hasn't changed sana. It's just, it's a probability. So probabilities don't change much. So when you start seeing things that are over and above what was there before, possibly it's the environment. And one of the big things, I mean, if you look at a day, kile umekula, utaniambia ni kitu gani original. Kama ni fruits, zimewekwa pesticides, right? Kama ni mkate, imewekwa preservatives. So we are almost guaranteed to eat, we eat foods that are processed, right? So that gives us an increased risk. So that is for everybody, because we are all eating the same food and we are living there. Lakini kuna watu, a specific group kwa community, ambao wako na genetic risk ya cancer. Sasa uongezee ya environment, ya inakuwa higher than normal.
And a follow-up question on that, someone is does not have a genetic or biomarker, and then they are exposed to a carcinogenic environment, maybe radiation, and then they develop some mutations. Do they have the capability of transmitting that mutation to their offspring?
Now, when somebody did not have it before, and then they get the mutation is not happening in the what we call the reproductive cells, either ovum or sperm. It's happening in a like a breast tissue, in this case, a prostate or ovary. That one is not going to be passed on to offspring. What is passed on is whatever genetic mutation is in the reproductive cells.
Okay. What kind of mutations are we talking about when it comes to breast cancer? When someone is about, let's say, they want to screen, what are these mutations that they should be looking out for?
Okay.
Yes.
So the first thing, when somebody wants to understand kama they are at higher risk than the general population of getting breast cancer because of inherited cancer risk, the first thing is looking at the family, right? Because there are certain families where it's very strong, so then the benefits of screening are more. There's some families where it's very little cancer, so the risk is less. I'm not saying the risk is zero, because the risk is always there. You cannot know what you have until you test. But because genetic testing is expensive, and someone might be worried about cancer, there are so many other diseases to worry about. So the first entry point is this person at increased risk of developing cancer? That is number one. Then from there, when we evaluated the family, then now we sit down with the person who is interested. Then we evaluate the benefits and of what they need to test for. Because there are very many genes, there are almost over 200 genes in our system that if they get a wrong code, they predispose to cancer. So then we look at somebody and say, okay, based on the kind of cancers that are running in your family, because these tests are very expensive. If you decide you're going to do all the genes for all the diseases, people might not eat, people might not go to school. So then we have to prioritize based on what the risk that you have. We believe these are the genes that will give us a higher yield, whereas taking into consideration cost. So that is step one. Looking at the family, discussing one-on-one. You can have different families na prescription itakuwa different because kila mtu anakuja na story yao na risk zao.
And what are the common mutations that are usually
so when we look at breast cancer, the commonest, and it's good the knowledge is out there, are the two genes that are called BRCA1 and 2. Those have been found to be the ones that are responsible, those two, for most of the hereditary breast cancers. Lakini kuna but a very big but. A lot of that information has come from people outside Africa. And we know people from Africa have different genetic makeup. If even you just look, uso yangu ya Mwafrika na mtu hajatoka Afrika ni very different. So then if you unachukua information mali pengine, you can't come and copy paste here. We need our own data to inform us what our true picture is.
Earlier you mentioned that breast cancer, either man or woman, there's a lot of misconception, and maybe it has led to stigma that men cannot get breast cancer. How true or how false is this?
Unfortunately, because of that stigma, a lot of men do not present early. Breast cancer can occur in men because they have some breast tissue, not a lot, some. About 1% of, 1% of breast cancer occurs in men. So it means for every 100 patients that walk into clinic, one will be a man, right? So the risk is there. And unfortunately, because they have little breast tissue, they present late. Treatment outcomes are actually poorer in men as compared to women. And even when it comes to heritability, the question I get a lot. So you have two sisters who come to clinic, wanakuambia, ukiangalia familia yetu, my auntie had, my mom had, my grandmother had. Lakini wanakuja sisters, brother wanaachwa nyumbani. But when it comes to heritability, inaweza kuwa hata walipata from their father. So kila mtu is at risk. The genes, hata kama the girls who say my dad had prostate cancer, so hainihusu, inakuhusu because the genes that cause breast cancer anaweza kuwa alikupatia. Utapata prostate cancer because hauna prostate, lakini you are at risk of other cancers. So hii segregation ya hiyo ni ugonjwa ya wanawake, so me I'm safe is not it, because if you got the genes then the risk is still there.
So in my from what I've understood is that some of these gene mutations, they carry more than one cancer. So let's say someone has a gene mutation of the BRCA1, BRCA2. It doesn't mean that it's only for breast cancer alone. It causes other cancers.
Remember, if the mutation is inherited, it's in all cells. Breasts, skin, lung, everywhere. It's just that it's been shown to be high in breast, but it doesn't mean it will only occur in breast. And when somebody has hereditary cancer alafu apate breast cancer, hiyo imaanishi hiyo ni mwisho wa safari. Unfortunately, anaweza pata cancer ya pili na hata cancer ya tatu. Right? So that it just means they are at risk in all cells, hata zile za making babies, reproductive cells. So then the risk is heightened, not only for breast, ama ovary, ama prostate. Those are the majority. Lakini we should not lose focus on. It can happen in other tissues and organs.
Okay. Still staying on the family aspect. Familia ya cancer na cancer yenye iko inherited genetics na familia ya cancer. There are two different things. How different are they?
Unajua, when we say familial disease, tunaona iko kwa familia. So we have to tatua why it's in the family. Is it because ni kwa genes? Ama ni because mali wameishi kuna an environmental toxin that inafanya itokee. So ni mpaka tutatue, tuende to the problem. We find out, is this actually hereditary ama inatokea kwa familia because of watu wakikaa pamoja, environment ni moja. So diseases tunataka kujua, is it because of the genes? Is it because of environment? But most of the time it's the two.
Now, next question. Let's say if a mother or sister had breast cancer, does it mean that the daughters will definitely get it? And how does inheritance actually work, of which you've already explained?
I like that question, and I want to change the question. If a mother has breast cancer, does it mean her girls, her daughters and son are at risk of cancer? Because now that we need to move away from inafuata to the ladies in the family. So they are at risk. It's not 100%. Because when you look at most cancer genes, they are what we call autosomal dominant. So she has a 50% chance of passing the abnormal gene. It also means she has a 50% chance of passing the normal one. So mtu anaweza kuwa na hiyo family, akiangalia for the last 4 generations inakuja hivi, lakini aepuke apate the normal one. For that person, we will know when we test them. So there is the risk of inheriting the gene. But it doesn't mean everybody who inherits an abnormal gene will develop cancer. And that is where the science has not reached. Unaweza kuwa na mtu akona hiyo gene na anakuuliza, daktari, nitapata cancer? And the answer is, hatujui. There is no solution. So then what now we tell people, you cannot change your genetic disposition. You cannot change the genes you inherited. Lakini, we can modify an environment, right? We should start being careful of what we consume. Biggest carcinogenic ni cigarette smoking. Mtu akitoa sigara kwa maisha yake, ana reduce risk of cancer, risk of heart disease. Yani sigara ni kitu mtu akiepukana nayo ataepusha magonjwa mengi. Being a bit more conscious of the foods that we consume in as much as we can. Exercise, right? We are unfortunately a generation, and the generations behind us, ambayo maisha imekuwa tamu sana na si kitu mzuri, right? Unaweza maliza mwezi moja, ukiangalia ile mazoezi mwili yako imefanya,
it's almost zero.
Kidogo. Either ukitaka kutoka point A point B kuna boda, kuna matatu, kuna gari. Ukienda mahali unafanya kazi, hata kama ni kwa soko, kuna kiti kukaa. Lunch time processed food, so that we are not moving around as much as we do. So even na si cancer peke yake, heart disease, diabetes, obesity, a lot of it ni vitu kama as a society, and it's very good. Unaanza kuona watu wameanza kuwa conscious siku hizi. 10 years ago na sasa huwezi compare. Weekend unaona tu watu wakipiga malaps zao wanafanya exercise. So it's a good movement that will start to reverse the issues that we are having. Because nimesema zile genes uko nazo, hakuna kitu unaweza fanya. We are stuck with them. So hizo hakuna vile tutashinda tukizipigilia nini. We have to find, so then what else? I have this genes, hizo siwezi change. Can I start reducing other risk factors? So that is where we need to focus our energy. For people who have family risk, it's a very scary prospect kukuja kupimwa. Right? Na hiyo jani, mi kama daktari na sijakuwa na shida kama hiyo, siwezi sema na understand vile wanasikia. But it's something that is not easy. Kuna watu wanakuja, tunapata yes they got the mutated gene. Then for cancer, it means that patient will try everything that we can to screen them more regularly, to try and alter their lifestyle so that we reduce cancer risk. And then we try and get cancers early, because one of the biggest things that zinafanya cancer ikuwe more manageable is early detection and treatment, right? Na saa zingine mtu anakuja, like I said, unapata hiyo shida, you confirm uliepuka. So then that gives also peace of mind, because genetic testing is extremely expensive. So ni kitu sana watu lazima waingie kwa mfuko, na hiyo mfuko siku hizi ni iko very shallow. Iko very shallow, ama saa zingine hakuna mfuko. Acha hata shallow, mfuko haiko sawa. So it's it's not an easy journey for a person or a family to walk through. Those who choose to walk through, their support systems to try and guide them, but ultimately it boils down to individual choices and what somebody feels comfortable that they're able to handle.
Now that you've mentioned genetic testing and screening, in Kenya, do we have facilities, or is there genetic testing going on in Kenya? And if, and a follow-up question to that also, who should go for screening, genetic screening?
So the answer is genetic testing is going on in Kenya. The story now is much better than it was 5 years ago. We still have a long way to go, right? So everything, I mean, systems are set up over time, but the beauty is even the ones that are not being done locally, they are being shipped out, but the drive now is to make things local, because when you localize things, they become even cheaper, right? So yes, it's being done, not to the capacity that we wish it was, but we will get there. The second question,
who should go for genetic screening?
Kila mtu hii dunia, kila mtu alikuja peke yake, si ndio? So kwanza unajiangalia na unaangalia familia yako, because nimesema today we are talking about breast cancer. We have about 20,000 genes in our body. Like tumesema urefu wako na wangu kuna formula tulipata, right? So determining which genes to get tested depends on family history, number one, because mtu anaweza sema leo nimesikia drive ya breast cancer, wacha I go get tested for BRCA1 and BRCA2. Lakini ukiangalia familia yao, ile inafaa atestiwe kabisa. Labda kuna ugonjwa kama sickle cell, ama hemophilia, ama some other diseases that cause hereditary dementias. So the most important thing ni kuangalia familia yako, tuone ni nini ni magonjwa gani hereditary ambayo ya katika hiyo familia, and then we are able to advise, because tumesema the tests are expensive and we need to plan. Ni kama mtu akienda hospitali aseme nataka full body check-up, a full evaluation. First unaangalia what is their age, what is their gender, right? Because hatutafanya PSA in a lady,
yeah.
right?
Yeah.
Or a pap smear in a man. So it's tailored according, and then what diseases have they had. Mtu akikwambia amekuwa na ugonjwa ya sukari, kuna test nitafanya. Mtu akiniambia ako na hepatitis B, kuna nini. So it's informed by individual history and family history, and then we are able to map out what is the best genetic screening. Now the difference between screening and testing, screening is when you're looking at people without disease. So anataka kujua ni mtu ana cancer, anataka kujua did I inherit an abnormal breast cancer gene. Genetic testing ni mtu ako na disease, anataka kuconfirm kama ako na hiyo. So screening is for healthy population, testing is for watu already wako na ugonjwa, in this case breast cancer.
So as a case scenario, a lady amekuja amefanya genetic testing, amepata ako na the carriers, ako na the hiyo genetic biomarker yenye na cause breast cancer, and then she opts for mastectomy. Will it help?
Okay. So first, that decision is made by an individual, not a health worker. I even get patients wako na test, anauliza daktari, is it advisable I do this? But decisions ultimately are for the patient to take, because maisha ni yake, right?
Yes.
How mastectomy, so it's on an individual basis, it's not for all. So for a patient who has decided this is the route I want to take, they are supported, we discuss what are the thought processes that led them there, right? And why it works. Remember we said breast cancer occurs in 99% of breast cancer is in females, because they have more breast tissues. So when you remove breast tissue, you reduce the risk, right? If you remove ovaries, zimeenda, huyo mama hatapata ovarian cancer, because ovaries,
they are already gone.
So it reduces risk, right? Because you've removed the tissues that are involved. So it's actually risk reduction, not risk removal, because like breast, you cannot remove 100% of the
cells.
So then it's for people to decide, but it's actually a treatment option for those who find that is the avenue they want to take.
And now some Kenyans might say, I've had some say that I was willing to do this testing, but I'd rather not, because chenye unatafuta ati utapata. What do you have to say to such kind of mentality? Na pia because it is understandable, labda ameona amekuwa traumatized with someone close, ameona bedhe nikipima labda itapatikana, na ikipatikana itaamka.
Haya, hapo tuko stage ya denial, and then hata hiyo ni watu wanataka kujua nikitestiwa hatuta change. Remember, like you must have been in our era before ARVs came, people were scared to test. I mean, disease, getting a diagnosis is scary, but once you start having ARVs, mtu anaona the story is changing. They are still scared, but they have hope. Nipimwe, nianze dawa. Na kutopimwa imaanishe una ugonjwa, si ndio ugonjwa itaendelea. So even now with genetics, a lot of genetic diseases cannot be treated. So even one of the questions I get, so then what? You test and do what? For cancer, it's a different story, because mtu unaambiwa go for your age, general population, a mammogram can be done every 5 years. But huyu akipatikana na a mutated BRCA, anaambiwa you don't do 5 years, go every year. So you see they have been put on a more strict regimen, right? So then we are hoping to cast cancer early. So the fear is there, but looking at what the benefits are, it might outweigh that. But at the end of the day, it's an individual's choice whether to or not.
You've mentioned something very important about mammograms. What are the importance of doing a mammogram, and who should not do and who should do? Because people out here, information iko kwa system. Mtu anakuja kwa facility, nataka unifanyie mammogram.
Kuna, we are talking about female breast cancer. There are about 3 tests: breast ultrasound, mammogram, and MRI. Right? They all have their benefits and some of them is cost. It depends on somebody's risk. One of the biggest risk factors is age. So ukiangalia useme tuko Eldoret, unataka kuplan a program for wamama wote wa breast cancer, you'll have more strict or more closer appointments for breast cancer examination screening for the older women, because that is the biggest risk factor. However, when you look at people with genetic risk, then they fall into the high risk category hata kama ako 20 years. So then the test is not informed. Hakuna blanket ya kila mtu atapata hii. It depends on risk, it depends on age, it also even depends on things like breast tissue and how the structure is to inform which screening. But over and above testing, because testing mtu atambua ende annually if they are high risk or something, self breast examination, because what happens in those intervening 12 months, self breast examination is something all women should
learn.
Yes, and I think you said you had a podcast that was on self breast examination, and it was very well received. That is the first step, right? Ni kama kukuja hospitali na malaria, right? Kuna dawa ya malaria, yes, but what will save that child is a mother or a father recognizing huyu mtoto ako na fever, akuje mapema. So it's not what we do in the facility, it was is being done at home. So first is self breast examination and regular, so that people learn to know what their normal breast feels like, and it becomes very easy. Mtu anasema hapa kuna kitu imechange.
Yeah, something is wrong. And upande wa genetics, how was genetics, let's say genetic screening or genetic counseling, how has it helped shape the treatment of breast cancer?
Okay, so there are now specific treatments that are for specific mutations, right? So that if somebody is found with a specific mutation, anawekwa hii dawa, ule hana awekwi. So it starts giving, not all cancers are created equal. So it's, you find what exactly is driving this cancer, you hit it. That's why it's called targeted treatment. It's targeted at specifically what is driving that cancer, and then that is what's going to improve treatment outcomes. So it's shaping treatment for not only breast cancer, it's quite a number of cancers.
What practical steps can ordinary Kenyans take to prevent or catch breast cancer early, with or without genetic testing?
Yeah, very good, because not very many people watafika stage ya testing.
Yes.
Na tusemi all, how many adults Kenyans are there?
Around 47.
40 million. Na tusemi kila mtu 40 million adult aende apange apimwe genetic testing ya breast cancer risk. Simple things, lifestyle, right? As much as possible, try and live what we call a healthy lifestyle. That is step one. We exercise more, we eat healthy, we try minimize alcohol, cigarettes, and all those things that are bad for us. But then we also look at within ourselves and our families and see, am I at heightened risk of having something hereditary? Then those are the people we start advising to come to hospital. Ama they go to hospital and then they are told, based on your biopsy results, there is likelihood that this could be inherited. But kwa community, we try, because genes zile tuko nazo, tulipatiwa hizo ndio, lazima tupambane nazo. So then now we try and modify what we can. That will not, our genes cannot change.
Your strongest message to Kenyan women?
And Kenyan men. Yes. Kenyans.
And Kenyan men.
Or non-Kenyans.
Yes.
Anyone.
To Kenyans, what is your strongest message to Kenyans? I've omitted women and men.
Kila mtu.
To Kenyans now, in regards to breast cancer, let's say breast cancer awareness and genetics. Yes.
For us, genetic screening is one small ammunition. Kama if we are an army, right? Kuna tanka, right? Hiyo itakuwa lifestyle. From when children are growing up, we should start, and it's happening. People are being more health conscious. So that is the big guns, right? The other big gun is regular screening. From, we are talking about breast, so self breast examination every month is what is recommended. And then now going to hospital to have radiological screening when it is recommended. And then now depending, so that is for everybody, the big guns. Genetics testing for heritability is just one kale ka bullet kadogo now to complete the nini, so that we try to win this battle that is breast cancer.
Now for is now for the healthcare workers. There are some of those healthcare workers, some practitioners who would love to maybe get into genetics, mambo na genetic courses. What does it take?
That's an excellent question, and we need a lot of people to take it up. Number one, it's interest and passion. That is always the first step.
Interest,
right?
and then passion.
Mtu anasema leo nataka kujua kubake, I like baking. Nataka kujua kubake. Ataenda atanunue manual, anunue baking tray, asome sasa nitakuwa natumia butter, right? So there is first the interest, alafu mtu anasema nitachukua time because the other ways sema hakuna keki, ni wewe umeamua, hautajua. All that information is out there, so it just takes but those conversations, I'm very happy people are starting to see it as a viable career path.
So in Kenya, do we have more of specialists in genetics? Ama bado it's still something that is coming
we are
up?
nowhere near what we need, but every journey begins with a few small steps. And I think that train imeanza kuenda, so hata patients are getting on board. You have people, mtu anakuja si hata kitu daktari anaanza anasema nilisoma hii nataka 1 2 3 this genetic test, so everybody is coming on board because genetic data the tests are becoming commonplace, so ni kitu inaendelea kuwa in high demand. So the paths are there, mtu akitaka
ana develop interest alafu passion and then
alafu anaamua hiyo ni njia atashika.
So for you to get this level that you are a physician and also specializing in genetics, how long did it take?
That's a very interesting question. Because how long did it take? Silianza wakati nilipelekwa nasari na wazazi, kitu inaanzanga huko, so ni miaka yote then you find you're just building. Hata before uende shule bado kuna mtu alikulea, si ndio? So inaanzanga huko nyuma, but ni kitu unaenda unaongezea. The beauty of being an adult and an adult professional and an adult learner, mtu uchukua path yake. Kila mtu anamaliza shule, kama we mahali unaketi unaona hii ndio inanifaa, oncology si renal ama critical care. Na mtu akifanya uamuzi, you are doing something that you are driven to do, right? So hakuna kitu itasimama kwa njia yako kufika mahali unataka kufika. Imechukua kutoka nursery.
So it's something that builds up to the expectation. Okay, I think without further questions, I think that is done on genetics in breast cancer. It's been a pleasure. Imekuwa in a short notice, but at least we've showed up, and looking forward to having more conversations outside genetics.